everybody. Not sure if you can hear me. I think everything is up and running and we are live. So I am, all right. Hi, Shirley. I'm going to wait here. Dr. Ramasamy is going to join us any minute now, and we will get started on kicking off Infertility Awareness Week. And Dr. Ramasamy and I are going to be talking about all things related to male fertility. We've received a ton of questions. Thank you so much to everybody. And thank you so much to everybody saying hi and giving me feedback that you can hear me okay. That's always so helpful. So waiting here just for any moment to see Dr. Ramasamy check in, and we will get started. But other than that, hi. Oh, so good to see you on. Lots of love to everybody joining us, and thank you so much for spending your evening here with us to learn a little bit more about some male infertility, which is really, really important. So we have the expert here joining us today, and we work together with him so often, which is fantastic. So let's see here. I saw him join. Let me see if I can try to merge him. Let's give this a try. This Instagram Live has changed a little bit. I've been off Instagram for a little while, so apologize for the little glitches. We're gonna get everything set up here. All right, we're gonna see if this will work. But other than that, I hope everybody's had a good week so far. There we go. Are we all live and connected?
Hey, how's it going?
Yay! Good to see you.
How are you?
Wonderful. How is everything? Oh, go ahead. Sorry.
I'm doing well, but why have you been off Instagram for a while?
I know. Life has been a little crazy for personal and professional reasons. I have had to devote some attention off of Instagram. So who better to come back live with than you? It's just so perfect and so fitting. And we're here. So I love it. And we have tons of questions already, but I think perhaps, since it's been a little while since we've done one of our lives, maybe we can talk a little bit about, just back it up, talk about the male infertility evaluation and maybe just how that whole process gets started. So perhaps let's hear you get that part started.
Absolutely. And let's say hello to all our viewers.
Yeah.
I'm Ranjith Ramasamy, one of the urologists, reproductive urologists at the University of Miami. We're very happy to work very closely with IVF-MD and certainly Dr. Sabrina Gerkowicz today. The reason we chose today as opposed to any other day is today is the first day of the National Infertility Awareness Week.
Right.
Infertility actually affects 1 in 6 couples in the United States, and the prevalence only continues to increase. I wish we knew the causes of all couples that come to us with infertility reasons. I feel like we would make such happier patients if we knew the cause for all of them. Unfortunately, we don't. Still, so much of infertility remains idiopathic, unknown, and I think I tell patients all the time that we're only scratching the tip of the iceberg, right? No matter how many tests we do, no matter how many IG lives we do, patients should not think that we doctors actually know everything there is to know about reproduction. Still to date, reproduction remains a miracle. And as much as we hear from friends all the time, oh doc, we went on this vacation, we got pregnant right away, that's just a chance. And so majority of couples that suffer from infertility, we still don't know the reason, but we try our best to A, find the reason, and B, try to optimize the chances for both the male and the female partner. But thank you so much for being here. We're happy to answer all of your questions. And we obviously got a lot both on my personal feed as well as IVF-MD, and we're very happy to take questions on today's session as well. So just to get started, I think we talked a little bit about male fertility evaluation. One of the basic things that all men try to do for starting a male fertility evaluation is get a semen analysis. Absolutely. It is probably the best test that we have for fertility today. It is also the worst test that we have for fertility today. But that's what we have, and that's what we're going to use.
Yeah.
Unfortunately, just because the semen analysis is normal does not mean a man is fertile. Just because the semen analysis is abnormal does not mean a man is infertile. So for all the couples that are listening out there, please just remember that just because an abnormal parameter on the sperm analysis does not make a man any less of a man, does not make him infertile, is certainly not the only cause for infertility. However, I think one time where the semen analysis is very useful is if it is zero. So if you absolutely see no sperm at all, or if you see all sperm are dead, then I think you can probably label that man infertile. So I think that makes the semen analysis very easy and interpretable. But any other semen analyses, when the counts are low, the sperm is not moving as fast, they're not shaped as well, just make sure all of you know that it is not necessarily a diagnosis of infertility. It is not the only reason why you're unable to father a child. And so I think it's just very important that couples understand that even though the semen analysis is the best test that we have, unfortunately, it comes with a lot of deficiencies on its own.
Absolutely. And the fact that it's so variable, and that's the part too that's really important, is that, one abnormal test, unless, like you said, if it comes back with zero sperm, still, you want to repeat this test within a certain time period, which typically at least is a month. But with that sperm cycle, to account for those changes, giving that 3-month timeline, and knowing that can be when sperm are created to when we see them in the ejaculate. A lot can happen in between. So those findings to be abnormal, definitely just say, hey, we need to dig a little bit deeper here and see what's going on, and definitely need to be repeated. The other test I wanted to talk about in addition to that semen analysis, of course, is then the DNA fragmentation, or some of the other more quality or function related tests. And I'd love to kind of hear you talk through that a little bit as well, because
sure thing. So just because you have a lot of sperm does not mean the quality of the sperm is good.
Exactly.
There's lots of things that we actually don't know about the sperm DNA, whether it is good, whether the quality of the sperm is good or not. Sperm DNA fragmentation is one of those tests. It's certainly not recommended by the ASRM, the American Society of Reproductive Medicine guidelines, to be routinely used in men.
Exactly.
But I can tell you, and I'd love to hear your take on this, Sabrina, is I get it in couples where I don't know what's going on, and in people who I think were missing something. Like a guy with all normal sperm parameters fails multiple IVF cycles or an IUI cycle. That's when I think about getting it. Couples that have recurrent pregnancy loss with really no abnormalities on either side, those types I get DNA fragmentation. Couples who fail IVF cycles wherein they've gotten embryos, they can't get to an embryo, where they have lots of eggs, lots of sperm, they fertilize, but all the embryos arrested all at the 3-day mark, So in those instances is where I feel like DNA fragmentation will certainly help a lot. And even DNA fragmentation, unfortunately, there are so many tests that people do. It's really not standardized as well. And so whenever couples are paying money for DNA fragmentation, because it's not a test that's covered by insurance, you want to speak with your doctor about what it is. And most importantly, come up with a plan ahead of ordering that test and getting that test, meaning what are we going to do with those results?
Exactly. Yes.
If the results predict abnormal sperm DNA, how are we going to act on it? Are we going to do something in the lab that's going to improve it? Are we going to do surgery on the male partner to try and fix it? Are we going to get sperm from the testis as opposed to the ejaculated sperm for the next cycle? Do you know what I mean? So come up with a plan ahead of time called a priori, and then make sure you execute that plan. Because once you get the test could be in the gray area, could be white, could be black. And so then you're just all over the place in terms of management options. So come up with a plan well ahead of time before you order the sperm DNA fragmentation.
Right. And I think it's so important too, because that one is a really tough one to quantify in a way. I mean, you're measuring something that is extremely important, and that is the DNA quality. But how does that affect typically the quality of your embryos or your treatment success and fixing it? These are things that we have our best information to guide us, but we still have a lot of unknown. Sometimes things like varicoceles or other factors, lifestyle factors, may actually be contributing from that quality level to how well the sperm is functioning. But can we identify what's the actual cause of that, and how can we actually fix it? And that's where really teaming up with someone like yourself, especially you know, to help us rule out some of those anatomic factors and see perhaps can we bypass some of these stressors to the sperm and go surgically, for example, or change our approach completely. So it's really important, but I agree, you know, it's something that we don't initially assume as part of a fertility evaluation, but truth be told, when people are coming to us and when they're getting to this level and you're really trying to figure out what is going on and if there's something that we can fix, I do tend to really include that as part of my testing, because you find things, and these findings do lower the percentage in terms of success, perhaps even with insemination or other kind of treatment, and they give you a clue that deeper testing or deeper treatment is warranted. So you don't want to miss those things and then go backwards and say, well, hey, why didn't we do this sooner? At the same token, sometimes you still get normal testing and things don't work, and that really requires even more deep digging. So it is a gray zone, but if it can add to our plan, all the better. So I agree with that completely. And how, you know, when you find these abnormal DNA fragmentation, you know, I know we're kind of jumping around a little bit. We're focusing on the quality, which tends to impact a lot of the parameters in theory. But, you know, a lot of times if the morphology or how the sperm appears looks a little bit abnormal, perhaps that might also raise a clue that could there be some other impact to that DNA quality if there's certain lifestyle factors, and certainly jump in to add some other things that, you know, may trickle down to affect that quality. That's where we want to kind of start that. And that's the clue in the semen analysis that tells us how can we start to improve this quality parameter of the sperm. But like you said, normal concentration, normal amount, normal semen analysis still doesn't mean that there's something not going on underneath the surface.
Absolutely. And I think there are several ways in which you can improve sperm DNA fragmentation.
Yeah.
I think you hit upon lifestyle a little bit. I think stopping smoking, weight loss, and if they do have excessive exposure to heat around the testicles, all of those can certainly help with improving sperm DNA fragmentation. A large varicocele can sometimes increase heat around the testicles and affect sperm DNA fragmentation, and certainly that is something that you can think about fixing. Daniel Gonzalez is actually a medical student working with us. He is recently publishing a study showing that paternal age. So as men get older, you know, there's lots of controversy on whether sperm parameters decline or not. Most of them think, oh, as long as I'm 60, 70, I still keep making sperm. I'm not like, you know, women that we keep making sperm forever. Excellent, but I think what we're now showing, the evidence points to the fact that the sperm quality declines.
Correct.
Right? Sperm keep getting made in a machine, and the machine gets old, and the machine gets rusty, and now you're making defective products, which cannot get fixed. When you're young, there is good repair machinery to fix all of the sperm DNA, but when you get older, it's not. So men in their 40s and 50s and 60s, maybe we should be thinking about routinely evaluating their sperm DNA fragmentation and thinking about options to fix it. Maybe in a young guy with a varicocele, you wouldn't fix it because the sperm DNA is normal. But in an older guy, even though the sperm parameters are normal, now maybe the sperm DNA fragmentation is bad, and you may want to be aggressive about treating that varicocele if it is affecting his sperm DNA. And certainly think about using antioxidants. And I think in the lab, you guys use the Zymot test routinely.
Correct. Yeah.
And that's obviously a very good test to sort sperm DNA that are not as fragmented. And finally, as a last resort, I guess in couples that have failed IVF cycles, then we've certainly done using testicular sperm extractions. So if there are 12 eggs during the second or the third cycle, if the first cycle has failed, and we all agree together that the reason for why the sperm the IVF cycle failed is because of poor DNA fragmentation, then we've obviously done testicular sperm retrieval. even in men who have normal sperm counts.
Right.
And specifically for this reason of DNA fragmentation. So those are all several strategies that we can use to try and improve sperm DNA fragmentation, or at least improve the success. Laboratory, surgical, as well as lifestyle modification and surgery. So I think that's an important thing that you should talk to your doctor about, to try to see how to fix the sperm DNA fragmentation if it is abnormal in your situation. And actually, this is probably a very good tip. Ejaculation frequency appears to influence sperm DNA fragmentation. So shorter ejaculation time appears to have decreased DNA fragmentation. So often when men come to me with abnormal DFI reports, I often ask how long the abstinence period was. And if it's like 6 days, 7 days, then maybe just repeating the test again with a shorter ejaculation interval is usually sufficient. So, before going and thinking about fixing surgery or worsening your age, easiest thing is to just decrease the ejaculation interval and see if that will help.
See, all the more you have to, if you have an abnormal test, before jumping too far ahead of things, just repeat, reassess, and kind of see what those underlying things are that you can possibly improve from the source. And I think we've had so many questions. I almost think it might be good to maybe start going over some of those questions together, we always run out of time. So
yeah, I know. So let's start. Yeah.
Let's see. So we received one here saying, so I am 35 years old and I have both undescended testes. Will you please suggest, can I have my own child? So this is definitely a really important topic to talk about on a lot of different levels. So I'm going to turn that one to you.
No, absolutely. So undescended testicles are a condition called as cryptorchidism. It's usually a congenital condition that boys are born with. One of the first questions that I would ask the guy that put that question to you is, are those testes descended now? Did they do surgery when he was a newborn to try and fix those testes or pex those testes to bring them down? And then the next, I would want to know what the sperm analysis showed. Unfortunately, in people with bilateral undescended testicles, the chance of having no sperm in the ejaculate is up to 70 to 80%. So it's pretty high that they cannot have sperm. But thankfully, data suggests that if you do testicular sperm retrieval on them, there's about a 50 to 60% chance that we can still find some sperm. So the option of having biological parenthood in the testes that have been pexed in people who've been born with undescended testicles is still an option, and that's something that you want to discuss with your doctor about.
But the timing of that procedure as well is one thing I wanted to address. Certainly if that's done early in childhood versus later in age, what those implications would be. And also prior to going for a surgical sperm retrieval, are there any kind of pre-medications or any kind of treatments that you recommend to try to improve the odds of that being successful?
No, it's a good question. So as long as that data has sort of like not borne out, you're always like, oh my gosh, the testes are not descended, get it down right away because it's going to cause cancer, it's going to cause infertility. Timing of orchiopexy, which is the operation to bring the testes down, does not appear to influence fertility outcomes in the future. So it's just the underlying condition that you don't. However, if you do have an undescended testicle as an adult, one of the first things that I would do is at least bring it down before and give it at least 6 months before you think about testicular sperm retrieval. So you don't want to take a testis that's in the abdomen that's in the heat. Testes are outside the body, right? They're cooler by 3 degrees. And if they're inside the body, they can be affected by heat and obviously affecting spermatogenesis. And so I think that's probably the most important concept there. And you brought about optimization of outcomes prior to testicular sperm retrieval. I think fixing the testosterone levels is very important, using medications like clomiphene citrate and estradiol to try and optimize the testosterone to estrogen ratio in all men who are undergoing sperm retrieval is probably best. And that should take about 3 to 6 months. And that's also something you want to speak with the doctor about. If your testosterone levels are normal, meaning more than 300, or intratesticular testosterone levels are normal, then please don't go and waste time medicating, right? Plan for the IVF cycle, get the process going. There is no point in waiting. Because sometimes patients are given false hope that giving medications will get their sperm back in their ejaculate. And if you have a normal testosterone level, it's unlikely medications are going to improve sperm in the ejaculate outcomes.
Yeah. Well, and certainly at that point, I know I kind of asked those questions on purpose because I know that they're kind of tricky ones, and certainly those dogmas of it being, it has to be done when you're a child, for example, versus, not. So every case is very specific, but at the same time, of course, being more proactive about it and then seeing what is the testicular function and what those odds might be. And hopefully, of course, the female evaluation is really important. You want to optimize both partners before going forward, but teaming up should hopefully give that option for building a family in that specific situation. So
Correct.
hopefully that will work out for this individual who sent us the message. Another question we got, we'll kind of trade off. I'm hogging the questions. I know you got some, so I'll let you do some.
No, okay. Okay.
But we had one here. This was kind of part of the DNA fragmentation question, so we probably already talked about it, but this was, what can my husband do to improve sperm decondensation? He is currently taking FH Pro, which is a fertility supplement for men. Is there anything he can do to improve sperm quality? So I think we kind of already touched upon that, but I guess specifically the decondensation aspect, there's a couple different things that are measured as part of the DNA fragmentation assays. So I'm not sure if you kind of stratify based on one of the two findings, but I think overall the recommendations we've already talked about apply to that as well.
I think so. So
right.
Decondensation, unfortunately, there's not as much data to back it up as much as we have in DNA fragmentation. But I would probably use the same approaches that I do with DNA fragmentation. It's not that different compared to DNA fragmentation. It's supposed to predict what happens after the sperm fertilizes the egg. The DNA fragmentation also does the same. What happens if there's a lot of parts of the DNA that are fragmented? Clearly, the embryo doesn't grow to be normal. And if parts of the DNA don't decondense very well, the embryo doesn't grow. So it's the same exact concept. I don't think we should interpret that any differently than the others. There's one question here, so I'll take this turn now. There's a question about sperm morphology. We've actually published data along with you guys about 2 years ago now showing that sperm morphology doesn't really affect intrauterine insemination outcomes, right? Because success still remains similar, even if it's 0% or if it's 1 to 4%. What do you actually use it for? Like if a patient has all normal parameters and his shape is bad, how do you counsel the patient? And then I'll tell you what my take on it is.
Yeah. And that's hard because, of course, you have to take it into the context of the full analysis, right? So, of course, if their concentration's normal, their motility, very important. You're taking a small sample of the sperm and you're quantifying the percentage of morphology based on that sample. And yes, it's supposed to be representative of the entire sample, but if the concentration is robust, and the motility is good, I certainly wouldn't rule that out as part of one of our available options, depending on the full picture. And, the male, the female evaluation, doing the two together is super important. And seeing whether this is a reasonable option in the context of their treatment plan. But, really hitting the lifestyle stuff hard, totally not to sound like a broken record, but, these are things that can still just be clues. Are there certain health elements that we should optimize? Are there certain exposures that we should try to minimize? All of those things, like you've mentioned, of course, smoking, let's see those things that we can kind of rule out and give them a chance to improve. But that in and of itself, exactly, because of the data, does not rule it out, but does just give me a little bit more of a red flag to say, are there other things that might be impacting quality here? But that's kind of how I would interpret that. So concerning, I don't know if it's the right word, but of course you want to repeat it. You'd want to see how things evolve and you want to interpret things in terms of the context of everything, but it still does leave treatment options open depending on the couple.
Right. Except for some really rare morphologies like global Azoospermia where there's no head. Morphology in itself as a quantitative metric doesn't seem to be very useful to me. As a qualitative, if all the sperm that are being seen have pinheads, they all have bad necks. Then it points to me some sort of an underlying genetic defect that's causing all of the sperm to be abnormal, and that could point to couples not getting pregnant. But if a few sperm have bad heads and a few sperm have bad necks and a few sperm have some droplets in their heads, I think those are not representative of, quote, abnormal morphology. So I think In few years, I think we'll probably go towards a qualitative way of just doing morphology as opposed to quantitating at 0%, 1%, because it is alarming. Patients get very
Oh,
concerned
for sure.
when they see
It's
that
like,
0% on there, and they ask us, "Doc, all my sperm
of
look horrible.
course.
All my sperm."
Yeah.
And it takes
It's
a lot of counseling on our part to say it's okay for all the sperm to look horrible, because in normal fertile men, only 4% of them even look normal.
exactly.
96% of men, 96% of the sperm in fertile men look abnormal. And
Which
so,
is pretty jarring, and
yeah,
it's extremely counterintuitive. So
that's
it's a very hard thing to get your head around. But that's where hopefully, exactly like you said, with the exception of these really specific abnormalities that do compromise the function because components are missing that are critical and so forth. But it's going to be a tough one, and you're right. Until we can improve that measurement and make it a little bit more translatable,
right.
we're kind of in this gray zone where we just really have to take it case by case and try to just say, hey, it sounds awful, but hopefully, we still have options. So
Right.
we have here another question going from the live one. So what is your recommendation for abnormal sperm aneuploidy test and history of failure of implantation after IVF? Is there a sperm selection test you recommend? And they mentioned the Zymot test. So
Got it. So sperm aneuploidy is very different from sperm DNA fragmentation. So DNA fragmentation is where the sperm DNA is just broken in multiple places. Sperm aneuploidy is an abnormal number of chromosomes. The easiest thing for people to remember is the Down syndrome. People have an extra chromosome on 21, and so therefore they develop Down syndrome. Klinefelter syndrome, some of us know, it's an extra X chromosome, it's X chromosome. So we're all supposed to have 46 chromosomes and an X and a Y. So it's basically 23 chromosomes. Sperm has 23, egg has 23, and they merge to get 46.
Yep.
If the sperm has 22 chromosomes or 24 chromosomes, then it can be abnormal. So that's what sperm aneuploidy tests. We all wish we could test the sperm and the eggs, but the eggs never come outside to get tested. And so you can never test the egg because they're pretty fragile. But sperm are pretty robust, and they can get tested, and so therefore
we can't use them. We can't test them and use them, so we can't be that selective. We just have
That's
to get
true.
a sense. So
we just have to guess. So,
what's the
but at
sample?
least it gives us a clue on what to do with the sperm. And, and sometimes if the aneuploidy is bad, maybe couples should be thinking about donor sperm. But like the viewer mentioned, using Zymot really doesn't help pick sperm that are euploid, meaning with normal chromosomes. So unfortunately, over there, the options are even testicular sperm will not get you better sperm with better ploidy or better number of chromosomes. It's unfortunately a genetic defect, a failure of recombination and meiosis, and so therefore it's tough for us to sort sperm with normal chromosomes. So that's what the test is. It's very different from DNA fragmentation, and I use it even more rarely than DNA fragmentation.
Exactly right.
But that's something that you want to speak with your doctor about.
Right, and for the big picture of implantation failure, that's a really tough area where
actually along the same vein, we're talking of aneuploidy. I mean, you guys do routinely or almost routinely pre-implantation genetic testing to look for euploidy and aneuploidy of the embryos. Exactly. How often do you do it? What percentage of couples these days are getting pre-implantation genetic testing, and which couples are actually not getting it? So why don't you give us a clue on that?
It really has evolved. This really was something that kind of started for a more select kind of age population where you were targeting, especially once it's no longer that 50-50 odd of whether this embryo is going to be chromosomally normal or not, and that tends to really be very dependent on the egg age. And so somewhere between 35 to 37 is sort of that middle of the seesaw where it's about a 50-50% chance, and then from 38 onward that starts to slowly decrease beyond the age of 40, even sharper and sharper and sharper. So in couples, or when you're using eggs from a female over the age of 38 and certainly 40 and beyond, that's when those choices to do the pre-implantation genetic testing for aneuploidy do become more common. In couples that are younger than that, it really depends on their history. You know, are you looking at some of these cases kind of, you know, of course we don't know the full details, but from what is being described from that one question, you know, is there some other reason why perhaps we want to have more information about that embryo status, to know, is that a way that we can try to shorten the time to pregnancy, be more selective in the embryos we're choosing for transfer.
Got it.
You know, so it's,
So if you were to pick a number of
yeah.
100 couples that are undergoing IVF with you, how many would you say are getting PGTA, and how many are not? Pick a number. You could pick.
Wow. You know, I should count this. I feel like if you're asking just for me, you know, I probably should see. But, you know, honestly, I would say it's definitely over 50% are choosing to go forward. And certainly in the couples where the age is 38 and above, even now 37 and above, I would say probably the majority are choosing it. It's one extra piece of information. It can increase our odds of that transfer being successful per embryo, because that embryo will just have a higher potential of being successful per transfer. So I would definitely say over 50 as a whole. That includes a lot of the younger women as well, but gets to be much higher than that in the population above.
Got it. Very good. And how accurate is those tests? Because, you know, I have couples who go through the whole process and rigmarole. Sometimes we get sperm, and then they go through the embryo. They actually have embryos, and then all the embryos come back abnormal. You know, they've got to go back and start at the drawing board, and they're almost hesitant to transfer those embryos because they're scared. How often would you think, you know, is that reliable? And one of your viewers is asking, are there effects or consequences to even getting the PGT done onto the embryo?
Yeah, so, you know, of course, you really rely a lot on your laboratory testing for the, you know, where the tests are being run. So the pre-implantation genetic testing labs have a lot of quality controls. You know, they're double checking and verify their abnormal results, you know, running various lab tests to do this. So, you know, that accuracy, we're hanging our hat on that being with very, very, very accurate. And when we get those results, like you said, if we're ordering a test, why are we ordering it, or what are we going to do about those results? So if we're seeing those results, we're going to trust those results. So is it common that so much of this is age dependent, right? And so many of this is dependent on perhaps the number and the batch. But pretty consistently, I'll get results that match with what I quote per age. So depending on how many embryos we make, depending on what that age is, we further stratify and walk down that you know, that little chart to see how many would we expect to get normal range. But it really does vary. For all of them to come back abnormal really is more likely in women who are above the age of 40, more 41, 42. Those are the incidences where, unfortunately, you know, cases happen where we have a couple embryos to biopsy and it's not abnormal for them to come back. You're looking in that age range of about a 30% chance of those embryos being normal. So
got it.
Those odds drop quite a bit, unfortunately.
And there's a question about fertility options for couples post vasectomy. How do you know, we obviously, as urologists, we can offer vasectomy reversal, and we can also offer sperm retrieval along with, you know, assisted reproduction. One of the factors that I often use is female age and female factor infertility.
Yes, for sure.
So if the female is older, I think you just define 37, 38. And certainly if they have female factors, sometimes young females can also still have diminished ovarian reserve, PCOS, endometriosis, some sort of female factor infertility for which they need assisted reproduction anyway. I sort of steer them towards doing sperm retrieval with IVF ICSI. Certainly if the female is young, they're healthy, they've been evaluated by physicians like yourself and say everything is normal. And if the male, regardless of his time interval since the vasectomy, I at least offer the vas reversal as an option. Certainly if they want to proceed with it, success rates obviously vary based on what operation I can do in the operating room, based on whether I see sperm or no sperm. Obviously banking sperm during the vas reversal is an option in case the surgery doesn't work. They always have sperm backed up for IVF ICSI. So that's what I use. Do you have any other suggestions or thoughts in a post-vasectomy couple?
Yeah, I mean, I think, of course, we're referring those cases to you for that evaluation and the physical exam and the history to see. But so much, you're right, it depends a lot on the time window. So, a 40-year-old female, that wouldn't be the most efficacious way to proceed, because you need to allow that surgery to happen and to heal and to test for that return of sperm to ejaculate. So this really is something more tailored towards younger couples and without obvious female fertility parameters, or big picture family planning goals. That's another topic that I'll be sure to hit with a couple, just to kind of get a sense, because that can be very meaningful in terms of our big picture plans. So absolutely, that's an important.
I mean, the one thing that I've seen quite a few now, especially, is gender balancing. So there, vasoreversal is not an option. I usually absolutely proceed towards IVF with PGT to identify gender. I don't even offer vascular as an option, but that's one slam dunk indication not to do vascular.
No, that's a good point. If that's why they're coming to you, then you're already going to the IVF option with genetic testing. So that does make quite a bit of sense for sure. I have a couple questions here that we also got. So of course, very hot topic, the COVID vaccine affecting men's fertility. That was one of the questions. So you are the perfect person to ask for this. So we can't go too long.
So I can tell you that that at the University of Miami, we're probably the only site in the whole world that is doing the first study on the impact of COVID vaccine on fertility. I cannot count the number of emails that I've gotten worldwide to answer those questions. I send it over to Dr. Daniel Nassau. He's one of our fellows, and he responds to pretty much 2 or 3 emails on a daily basis from worldwide about concerns on vaccine for fertility. 2 things. One, I can tell you that the study is ongoing. We expect to have final results by May. And so we will do an IG Live once those results are out for sure, because I think it's going to be one, very popular, and 2, something that people are still waiting on, not just for themselves, but now that we're vaccinating the adolescent population, 12 to 16, and we may end up vaccinating the kids as well very soon before the fall semester starts, both in colleges, in high schools, and even younger population. I think it's becoming a much more relevant and a hot topic that we need answers for, and we just don't have the answers yet. But I can tell you, just based on biology of what the vaccines are made up of, we don't think it's going to affect fertility. We don't. COVID virus by itself, I think, can impact fertility. Thankfully, we've published now a study showing that it can impact fertility in the 3-month time point, but at 6 months, it appears to recover. And so that's obviously very good news, meaning that it does have an acute impact, just like any other illness would.
Exactly.
And COVID seems to do the same thing, but the vaccine, just based on biology, should not have an impact. But for all those eager, enthusiastic listeners out there, just hang on tight. We will do an IG Live once the results are published to reassure. We've recruited a total of 48 people so far on the study, who've obviously obtained semen analyses prior to getting their 2 doses of either the Pfizer or the Moderna vaccine. And so once their 3 to 4 month time point is done post-vaccine, we should have those results by May. So looking forward to it. That'll be a separate IG topic on its own.
Yes. Oh my God. So, I mean, so important. And what you guys are doing is just, I mean, first of all, it's literally you. It's in our backyard. This is amazing. And it's so relevant. And, I think certainly another live come those results would be very much appreciated. Just there's so many questions. So
no, I look forward to doing that with you.
Yeah. So here we have one. So in which cases is azoospermia reversible?
That's a good question. So azoospermia, I think there's also another question about azoospermia early on whether
with Clomid
can help. So azoospermia is a condition where there is 0 sperm in the ejaculate. We talked about how it's very useful. Semen analysis is very useful when we started early on because if it is 0, then it clearly tells us that there's either 40% of the time an obstruction defect, meaning somewhere along the way the sperm is made, but it's getting blocked along the way. 60% of the time it is because of a production defect, meaning you're just not making enough sperm. You need up to 1 to 2 million sperm inside the testis to even make 1 sperm in the ejaculate. So that's why in 40 to 50% of the time, when we do testis biopsies, we're still able to find some rare sperm which we can use for IVF ICSI in men who have azoospermia due to a production defect. Right. So azoospermia is reversible. If you have obstructive azoospermia, you're able to do reconstruction. The surgery works in about 30 to 40% of men who want to have a child through natural conception. But certainly obtaining sperm in those men and using it for IVF ICSI is certainly still successful in 50 to 60% of the time. Clomid, use of Clomid in men with azoospermia, unless the testosterone level is low, which in 30 to 40% of the men it can be low, taking Clomid can help in 3 to 6 months to have some rare sperm in the ejaculate. However, Clomid should not be thought of as a panacea. It's not, you don't just take some Clomid to see if you get some sperm in the ejaculate. It doesn't work that way. Up to 10 to 15% of men who can take Clomid to have sperm in the ejaculate can happen. So majority of the men, Clomid is not going to work if you don't have sperm in the ejaculate. And certainly I think we should talk about, there could be an underlying genetic cause, in which case none of these are going to help, such as Klinefelter syndrome or Y chromosome microdeletions, which we can do. And in those cases, medications are not going to help. So azoospermia can be reversible in about 50% of the time if it's a blockage defect, or if it's a production defect due to either a large varicocele or low testosterone, or some underlying cause which can be fixed.
Yeah, and it's hard because these cases, even a lot will fall into a idiopathic kind of bucket where, you do break it down into those two major categories. Like you said, is it a plumbing issue, or is it an outflow issue, or is it a production issue? And, either of those are going to be addressed very, very differently. And of course, if there's anything else even further impacting that, the success of that, either retrieval procedure or any of those things can be really affected. But the azoospermia cases can be really, really tough. You can do the workup. You do a lot of chromosome testing, Y chromosome microdeletion, hormone testing, and sometimes you still can't find a reason. And those are very tough cases. So, stuff you deal with all the time. But,
right.
I had here another one too. So this one, can my husband have a varicocele if he has a normal semen analysis?
Yes, they can. And we talked about this a little bit, where the varicocele doesn't necessarily need to impact the sperm numbers, but can impact the sperm quality, where it can affect the sperm DNA. So varicocele, thankfully, is a normal finding. It's present in 15% of adolescent males. And so most men with varicoceles will not actually have a problem with infertility. Right. However, if the couple is trying for 6 months to 1 year, they are unable to conceive, and the husband has a varicocele with normal sperm parameters, it's certainly worth getting checked out to see if there are other issues in which the sperm is affected from the varicocele, and to discuss on whether it needs to get fixed or not. So most of the time, varicocele doesn't cause any issues, but varicocele still remains to date the most common correctable cause of male fertility. And so that's something that you want to discuss with your physician about.
Definitely. And, I think with varicoceles too, a lot of times people might not even know that they have them, for example. Correct. And so the etiology of that is even, or the incidence of that is hard to know, but definitely exam is the best way to tell, and then seeing, does it play a role? And some cases it may not, and everybody's going to be really different. So, but nothing will trump that exam and just that one more step of evaluation, because a lot of times there's nothing we can test on the semen analysis or labs, that would necessarily tell us if something is there anatomically. So here, one more too. We've got tapered head or small head sperm. Can that cause miscarriage? So we talked a little bit about some of these defects, but maybe we can specify.
Sure. So I think, does abnormal sperm morphology alone lead to miscarriage? I highly doubt it. And I think there's really no data to say one type of morphology leads to miscarriage more than the other. But certainly, if there is recurrent miscarriage and the sperm morphology is abnormal, you want to think about ways to correct it. And we talked about how monomorphous, meaning if all the sperm are the exact same shape and they are all abnormal, that's something that needs to get investigated. Right. There could be some underlying genetic defect that's making all the sperm the bad way. But if it's polymorphic, meaning there's few abnormal heads, few abnormal tails, few abnormal necks. I think in those cases, I don't think that that's the cause for miscarriage.
Yeah. And then you're focusing on one parameter as part of a whole picture. And that's the part that's, I think nothing can point to that leading to this without a bunch of other stuff possibly, in need of investigation. So, but yeah, I think important to know and to be aware of what those findings are, because for the reason, like you said, if there is something that is really consistent or very kind of a very singular finding, that's less likely to be due by chance versus a particular reason. So, well, we've had this question here about ICSI.
And not using thawed out sperm. So I'm assuming the question is, why wouldn't ICSI not use frozen sperm versus fresh sperm? Would you pick one versus the other? What are your thoughts?
That's a good question, because because of course, whether the eggs are frozen versus fresh, what are the sperm parameters? Why was it frozen? Was there a reason? Was there a quality issue? I know certainly from the embryology perspective, sperm are pretty hardy and robust, and typically how they appear and how they look on the day of an IVF, whether it's the egg retrieval or an egg thaw, kind of hard to know without the full context. The embryologist will make those decisions to see whether or not ICSI is the most appropriate reason. It was really developed for a male factor treatment. If there was a reason why we needed to help facilitate that fertilization step because there was a concern of the inherent ability of the sperm to do it itself, whether it's frozen or fresh, that, might also play into the context. So a little hard to give the best answer for that. I'm sorry without more information, but
certainly, I mean, using cryopreserved sperm for ICSI is certainly used. It's allowed.
Yeah, for sure.
Especially guys that have undergo cancer treatment and have banked sperm for fertility preservation reasons. Certainly using thawing it out and using that for an ICSI cycle as opposed to sometimes even fresh sperm with ejaculate is recommended because we don't know what the effects of chemotherapy are on the actual.
Oh, for sure. But I wonder if they mean also like in terms of conventional fertilization versus, like the specific mode of the fertilization. So that's where I think
IVF is, very nice study, I think, that showed that IVF is almost never done these days. It's most of the labs are.
It's like way over 70-something%. But they're trying to dial back on that because really.
Oh, actually, a study was done in Emory where you trained Sabrina.
With the flux of, PGTA or the genetic testing, we thought we really needed to do, ICSI so that you were very specific and you knew that the genetic data came from one egg, one sperm. But now as things continue to evolve, that's no longer a pre-requirement per se, depending on the lab and the technology and stuff. So, it's a great technology. It's really for male factor and for fertilization failure cases and other things, but knowing why you're doing it is very important. Some practices just do it on everybody. Some people are it's a very hot topic. But,
there's one question actually back at you now for COVID vaccine. Couples planning for their fresh embryo transfer. They had a history of COVID. Now there's no longer antibodies. Do you recommend the female partner to get the COVID vaccine before their fresh embryo transfer? Or frozen embryo transfer, FET, sorry.
Yeah. Well, that's a great question. And truth be told, every doctor has a bit of a different opinion on this, so I would first and foremost, I can kind of speak a little generally, but, you really want to align with your doctor because they have a plan. People have different suggestions for timing. Having the COVID vaccine is something, of course, it's a personal decision. The data we have and from all of our major societies reflects safety, so from what we see, that is what we abide by and what we believe. But of course, and we know the implications of an acute COVID infection, either during a treatment cycle that cancels.
Or during pregnancy for that matter.
Or during pregnancy really escalates risk to mom and to the baby. So this timing of the COVID vaccine is one that I discuss a lot with my patients. And ultimately, if that's something they're wanting to proceed with, I like to just time it to where they allow their vaccinations to happen, their immune responses to mount, their body to kind of settle back down. We don't really have a specific time frame for that, but I think most people tend to be saying somewhere between 2 to 4 weeks, some a little more after the completion of the second vaccine for the 2 vaccine sequences. I can't say that you have to hold me to that. Everybody has a really different opinion, but I just kind of have a case by case conversation with a couple and try to time it strategically if we can to really finish the vaccine course with a reasonable amount of time before actually starting the treatment. So, but run it by their doctor for sure to kind of see what their thought is, and because everybody's so different about this topic.
Right. No, it's a good point. I mean, I think you mentioned the fact that major societies have all come in support of the vaccine.
Exactly.
The ABOG, the American Board of Obstetrics Gynecology,
Yep.
ACOG, the ASRM, of course, the American Society of Reproductive Medicine, they've all come out in
Exactly.
support of the vaccine, not just during fertility treatments, after fertility
Yeah,
treatments,
and during pregnancy.
during breastfeeding, during, you know,
Yes.
basically throughout the phases of pregnancy and reproduction. I think
Right.
they've come out with saying that it is safe. So I think that we just need to reiterate today to our viewers and the audience that that's what the major societies are. But like you said, every doctor has their own preference, and whoever your physician is, speak to them, and maybe they can advise you on timing of getting the vaccine.
Exactly.
But certainly, if you've had COVID and now you don't have antibodies, you're obviously susceptible. So please do something about it. Either prevent the best thing you can to not get COVID, or go get the vaccine after discussing with your physician.
Right. Oh, it's a tough topic. It's really hard because we really don't know the best way yet. But that's where, again, you know, the more these studies come in, there's major nationwide studies, especially for pregnancy. The biggest thing is just trying to get enough recruitment from that standpoint to really start to understand that long-term data. You know, there's an Aspire study really centered out of UCSF or in San Francisco. So the more people we can kind of get enrolled from the pregnancy perspective, you know, you're hitting up some of the male factor and the male implications of COVID. So soon we'll just learn more, but all of us are learning about this in real time together. So it's a conversation, super important to be open and honest with your doctor and your team. And then let's come up with a good plan for each person. That's kind of how I've been approaching it.
Got it. And then there's a question about obesity and azoospermia and inability to increase testosterone. The best solution to obesity is not Clomid, not HCG, is really just weight loss. You can drown a guy in Clomid and HCG who's fat, and nothing's going to happen to his testosterone. So please discuss weight loss strategies with the patient. Surgical management of weight loss is certainly an option, and certainly trying to do sperm retrieval in a guy who is also very obese is also very challenging. And so for all of those factors, if the female age is, if she's still young and healthy, then certainly weight loss strategy is probably extremely important.
And also with the Clomid too, the impact of the estrogen level. So you're addressing with the Clomid and the HCG, you're trying to stimulate more of the testosterone, but that estrogen milieu is not helpful, and kind of quite counterproductive. So the only way to hit that even harder is, of course, just reduction of those adipose cells and those fat cells. So for health and quality and for so many other things too, that it's hard. It's a really hard topic, but it's so meaningful for sperm, for health, for everything. So definitely it would help that be way more effective.
Absolutely. Nice question by Daniel Gonzalez there. Microbiome, you know, vaginal microbiome, seminal microbiome. You know, we talked so much about how everything is idiopathic. You know,
that's probably part of it, and we just didn't know it yet. That's coming up for sure.
What are your thoughts on this? Yeah, you know, people are talking about, you know, catheter tip microbiome when you transfer the embryos. You know, the host environment where the embryo is being transferred. What are your thoughts on this? Probiotics, you know, so many people asking. What are your thoughts?
I'm certainly a believer. I know there's a lot of data to suggest that this is really impacted so much by health, by hormones, by gene expression. Like there's so many different things that can play into this microbiome and how does that affect health, pregnancy. I mean, that's kind of a tough area because it's hard to study. But I know, I mean, certainly back where I had trained, there were a lot of microbiome studies, especially more from the pregnancy, the placenta. We were really starting to do a lot more of that in the fertility space. The probiotic inclusion, you know, we routinely do use them, and I think that there is definitely a really important space for that. And certainly if that milieu is out of balance, it can be more caustic or negative to having that optimal environment for implantation or for treatment or any of those factors. So, but standard testing may not encompass that.
Yeah, you're right. And we discussed a couple today. You said it was a very difficult case. You know,
Yes.
semen cultures are coming back positive.
Yes.
You know, microbiome.
Literally.
Literally today. But, you know, microbiome may be the key. And I think
Definitely part of it.
Absolutely. I mean, that's something that we need to keep on the back of our mind and, you know, discuss that as a future, hopefully now research, but future clinical strategy for especially couples with this, I hate saying this, idiopathic infertility. You know, I wish we uncover more and more of this idiopathic and start identifying causes because it is so frustrating. And I'm sure, I don't know how you do it on your side, where this male factor is normal, female factor is normal, they get good embryos, the embryos look good, you transfer them, and you do PGTA, you do ERA,
you throw in the kitchen sink,
everything, and they do everything, and then they don't get pregnant. And I can't imagine a conversation you sitting with a couple after spending X number of dollars, going through all the tests, all the cycles, 6-month process, and now with no embryos and no pregnancy. It has to be frustrating from your end to have that discussion.
Absolutely. I mean, there's so much we have to learn. We have the most phenomenal and amazing field ever, but there's still so many answered questions. So, you know, exactly that, but that's all the more why these conversations have to happen. These collaborations have to happen. We have to look from many different angles and see how can we address this. But, you know, I think we're getting to that hour, which I can't even believe. And I feel like there's still have some more questions on the email that we didn't hit to here, but we will do this again. There's no doubt about that. And definitely send us some questions in the meantime. We'll store them and have them ready for next time. But just as always, it's so important to have that male factor evaluation. There's no better hands than your own and your team at University of Miami with the male fertility side. We cannot thank you enough for everything you do for all of our patients. You know, and especially this week, so important that we bring awareness and we just have these conversations. So thank you so much for chatting with me. And
absolutely. No, thank you for having me.
Everyone for their questions. They were awesome. So, but we'll do this again soon. Okay.
Bye-bye.
Bye everyone. Have a good night.
Good night.